Hi, my name is Stephen Alsop, and in this lecture we are going to speak about ethics. Now, this is a very important part of clinical practice, so just because this isn't basic science doesn't mean you should take it for granted. We will begin by speaking about ethical principles. Questions on these topics often appear as quotations and ask you to choose what should you say to the patient. An answer that is empathetic, open-ended, and non-judgmental is usually the correct one. But let's go with some specifics. There are four core principles in medical ethics: autonomy, beneficence, non-maleficence, and justice. So what is autonomy? Autonomy is the obligation to respect patients as individuals and to honor their preferences in medical care. This also applies to patients refusing care. So for instance, someone who says, "I don't want a flu shot." A patient who is competent and over 18 has the right to refuse any treatment at any time. Beneficence is the notion that physicians have a special ethical duty to act in the patient's best interest. Now, can this conflict with autonomy? Yes, sometimes it can. If the patient can make an informed decision, then ultimately they have the right to choose. Autonomy trumps beneficence. Non-maleficence is simply the physician's obligation to do no harm. This is the Hippocratic Oath. However, in situations where the benefits of an intervention outweigh the risk, a patient may make an informed decision to proceed with the intervention, even if there's a chance that the intervention may result in harm. Now, can you think of a situation where benefits and risks are routinely weighed against each other? Well, this is the case for most surgeries as well as medications. The last principle we want to talk about is justice, and this is the physician's ethical obligation to treat all persons fairly. Informed consent is a straightforward medical legal principle and requires three separate conditions to be met. First, there must be discussion of pertinent information with the patient. This is the disclosure of the information. Next, the patient must agree to the plan of care, which means they have to have both capacity as well as understanding. Capacity here is seen as the ability to reason, whereas understanding is the ability to comprehend what is going on. And lastly, the patient must be free from coercion, and thus they are acting voluntarily. Essentially, informed consent requires that the patient understand the risks, benefits, and alternatives of a decision, which includes no intervention. Now, on the exam, exceptions to informed consent are actually more likely to be tested than informed consent itself. If a patient lacks decision-making capacity or is legally incompetent, then there is no requirement for informed consent. If the doctor then decides to care for the patient, then he is exercising which core principle? That would be beneficence. Similarly, there's always implied consent in a medical emergency. Also, withholding information when full disclosure would severely harm the patient or undermine informed decision-making capacity can be an exception to informed consent, and this is called therapeutic privilege. An example may be a depressed suicidal patient who has a new diagnosis of terminal cancer. Since this is a controversial topic in clinical practice, however, you can be pretty confident that invoking therapeutic privilege on the boards would be the wrong answer. Depression and suicide will be discussed more in the psychiatry chapter, and you'll see how it ties into this concept better there. Finally, patients may always explicitly waive their right to informed consent. Informed consent can show up in disguise on the boards. For example, when a blunt force trauma patient comes into the ER, a question may ask your next step: go to the OR or resuscitate the patient and obtain informed consent. Now, this is important because the question is actually asking you if the presentation is emergent. Is it? Well, in this case, the presentation is emergent, and therefore informed consent is actually implied. So this patient should go to the OR. Consent for minors is sometimes a tricky issue and is commonly tested. So first of all, who is a minor? Okay, so anyone that is less than 18 years of age. And parental consent must be obtained unless that minor is emancipated. Now, emancipation can occur in a couple of ways. One, if the minor is married, this is my really horrible drawing of a ring, the minor has a baby, if they are self-supporting, or if they've joined the military. However, you should know that parental consent is not required for emergency situations, for contraceptives, treatment of STDs, medical care during pregnancy, and management of drug addiction. So one way people say you can try to remember this is to think of sex, drugs, and rock and roll. It's also worth knowing that parents, even if they are competent to refuse their own treatment, cannot refuse treatment for their children in life or death situations. So one way the boards may test this is by giving you an emergency room clinic scenario where the parent is refusing treatment. The first step is to decide if the scenario is indeed an emergency, right? So that requires some clinical judgment. If it's not life-threatening, then you should choose the answer that respects the parent's decision or delays medical decision. However, you should also be on the lookout for an answer choice that encourages healthy communication between the parent, guardian, or the patient. And obviously, if it is an emergency, then you should offer treatment to the minor, even if the parents are refusing. Medical decision-making capacity requires 6 conditions to be met. And again, this is related back to the concept of informed consent, because informed consent requires the patient to have decision-making capacity. So first, the patient must make and communicate a choice. Second, the patient must be fully informed. Thirdly, the patient's decision must remain stable over time. Fourth, the patient's decision must be consistent with their values and with their goals. And fifth, the patient's decision must not be the result of delusions or hallucinations. Finally, your patient must be greater than 18 years old or legally emancipated, which we just talked about. Also, it is worth remembering in these types of questions that a patient's family cannot require that a doctor withhold information from the patient. Again, there shouldn't be any reason to invoke therapeutic privilege on this sort of test, although in real life, those types of situations might occur. Can you think of a common situation in which a patient would temporarily not have medical decision-making capacity? So one example is if the patient was drunk or high. This is equivalent to being incapacitated, and so intoxicated patients that show up to the ER do not have medical decision-making capacity. Okay, it is time for a flash quiz. How can a minor become emancipated? If the person is less than 18 years old, they have to be either engaged, self-supporting, have children, or be in the military. So what is an advance directive? Advance directives are defined as instructions given by a patient in anticipation of the need for a medical decision. These statements can be either oral or written and are meant to champion patient autonomy by allowing the patient's wishes to be carried out. An oral advance directive is an incapacitated patient's prior oral statement that's commonly used to guide their wishes. Now, if the patient was informed, the directive was specific, the patient made a specific choice, and the decision was repeated over time, then the oral directive is valid. However, if any of these conditions do not hold, then problems can easily arise from differences in the interpretation of the directive. So maybe it's better to go with a living will, and this is called a written advance directive. Here the patient describes treatment he or she wishes to receive or not receive if he or she becomes incapacitated and cannot communicate their treatment decisions. Now, in most cases, the patient will direct the physician to withhold or withdraw life-sustaining treatment if he or she either develops a terminal disease or enters into a persistent vegetative state. Finally, the medical power of attorney is when a patient designates a surrogate to make medical decisions in the event that he or she loses decision-making capacity. In this context, the patient may also specify decisions in certain clinical situations similar to a living will. Now, the surrogate retains power unless it is revoked by the patient, making this more flexible than a living will. So let's talk a little bit more about surrogate decision makers. If an incompetent patient has not prepared an advance directive, individuals who know the patient, called surrogates, must determine what the patient would have done if he or she were competent. Now, I'm going to draw a family tree here to illustrate the order of surrogates. So we're going to go with this guy here as our patient. The order of surrogates is first the spouse, then adult children, then parents, then adult siblings. Now you can see the type of problems that could arise getting into this sort of hierarchy. There is no provision for which adult child should be given decision-making responsibility, nor is there provision for significant others who are not necessarily a spouse.